Good evening, everyone. Welcome to another episode of the Dr. Dustin Show. I am Dr. Dustin. It is Monday night, 7 p.m. Welcome, welcome. Come on in. I love that carry out. We are getting the hang of that, Kevin. I love that music. It is 90s alternative all the way. My jam. So tonight we are talking about something really personal for everybody. This idea that effort and motivation plays a role in pain management and recovering from pain management, and how often it is misunderstood not only by providers, by physicians or therapists, but by patients themselves. And I think we tend to beat ourselves up over and over and over again. So that's what we're going to talk about tonight. Welcome to the chat, everybody. So good to see everybody. All right, I'm going to take a drink of this. I hope everybody had a good weekend. We had a great weekend, by the way. The weather has just been fantastic down here in North Texas. Finally, we get the first 3 or 4 days out of the entire year where it's livable. A nice 60 degrees, sunny, clear skies. The children and I, we were on the trampoline Saturday night, just lying there looking at the stars, and it was so clear, crystal clear. You could see all the little satellites flying by. We got a lot of satellites, by the way. I didn't even realize that. I don't remember seeing so many as a kid. But, I love looking at space because any problems that you have here down on Earth really helps put it in perspective and helps the mind wander into something, greater than ourselves. And it was a good time. So tonight we're going to introduce everybody who's here. We got Evelyn in the chat. Hi, Evelyn. How's it going?
How's it going? Hi, I'm here today.
All right, and we got Kevin, of course, Mr. Producer, doing his thing in the back, flying through the buttons.
Trying to keep up. Moving fast.
I don't know if your mic is on just yet, Kev.
How's that?
Almost. He's going to keep working on that. So, motivation, boy, chronic pain is not just pain, as you all know. I'm speaking to the... Are you on yet, Kevin?
I think so.
Yeah. Oh, there you are. Nice. Okay. Welcome back. Chronic pain is not just pain. Many of you guys already know this. I am preaching to the choir. Pain is fatigue. Pain is fear. What's another F word that we can use to describe pain? It's screwed up. That's what it is. And it's essentially a nervous system overload, right? It's a loss of trust in your own body. And I would say it's probably very demotivating for somebody to, let's say, try a lot of different things to help recover, to help get better, and then they go in and they see their doctor or their therapist, and essentially the message that they get is, well, you just need to try harder, right? Now, they may not just come out and outright say that, but that could be the message that you get, wouldn't you say?
Yeah, absolutely.
I think what are some examples that we all have, right? Perhaps as patients, where this could be the communication. You go in, you see a doctor, you see a therapist, and you're like, well, doc, I've already tried physical therapy, and, I've tried changing my diet, and, but meanwhile, you're just kind of getting this stare but did you really? I don't know. I mean, have you really tried it? Because that's not the message I'm giving. Probably pretty demoralizing. So we walk away. We walk away feeling, I guess I'm just lazy, or people think I'm lazy. Which, wow, that's a lot to hold already. Given my inability to do all the things that I want to do, or I must come across by saying I'm weak or I'm broken, right? Now, I don't know about you, but I also know pretty well all the things that need to be done to live a healthy life, right? I know that I need to get 7-8 hours of sleep. I know that I need to exercise 3.5 hours a week or whatever, the recent recommendation is. I know that I need to eat healthy and avoid sugar and get more protein, but how often do I actually do it? Imagine now dealing with a chronic condition such as pain and realizing that perhaps those things are a path forward, are a path towards something better. But I just can't seem to cross the barrier, to climb the mountain, to get to from point A to point B, which always seems just a little bit over the bend. So we're going to talk about that tonight and really try to understand what's going on. It may not be your lack of willpower. It may not be that you're just lazy and struggling to participate in the plan of care, or maybe the plan of care isn't right for you. So we're going to dive into some research. It's quite interesting. Some people have really been looking at this for a while. And going back to 2014, Kevin, why don't you put on that first slide? We're going to look at some of what the research shows here. This was published in Science in 2014, titled Chronic Pain, Decreased Motivation During Chronic Pain Requires Long-Term Depression. Requires long-term depression in the nucleus accumbens. So this was a study that came out of Stanford University, and what I'm about to do is read to you some commentary about this study so that it kind of puts it into bite-sized terms for us. This was written by Bruce Goldman, again in 2014. So Schwartz and Malenka, they're the researchers, the primary researchers on the study, and their associates. They looked at lab mice. Okay, now the challenge with understanding this is still profound. We don't have a lot of human studies, and a lot of it looks at functional MRI studies and things of that nature. So we'll get into that in just a minute. But this was sort of the first big study as it looked at motivation and chronic pain and how that was affected. So looking back at the lab mice, these lab mice were given chronic paw pain. I mean, that's kind of cute, their little paws, but unfortunately they were hurting. And they were hurting due to either persistent inflammation or nerve damage. Okay. The mice also happened to be hungry. I think we can associate with this so far. The scientists then trained the mice to poke their noses into a hole to get a food pellet. At first, a single nose poke earned a pellet. But over time, the number of nose pokes required for a reward was increased. In essence, the researchers were asking these mice, how hard are you willing to work for your food? In essence, the researchers, so they were saying, okay, well, I know you're hurting, but we're going to put a barrier between you and your food and see how many times you're willing to push past that barrier to get your food. Will you do it 10 times? Will you do it 150 times, right? So within a week after the onset of pain, the animals grew increasingly less likely to work hard for food than the pain-free control animals were. Nothing too explosive there. But this begs the question, were the mice unable to work because their pain was too severe? Or was their failure to seek food simply due to lack of motivation? Now, it's important to note that the mice that had pain didn't have any movement problems. They were scampering about just in the same way as the healthy mice were. Okay. Also, when the mice were given free access to food, they still ate just as much as the mice with no pain did. So it wasn't that they didn't appreciate the food or they didn't have an appetite, maybe because of their pain. They still ate the same amount, but they weren't willing to work for it in the same way. So another difference is the researchers then actually treated the mice with pain with analgesics, with pain medicine. So let's take pain out of the equation now. But still, they were less likely to burst through those barriers to get their food. So this sort of led to the conclusion that chronic pain, in this essence, using mice models, contributed to a lack of motivation. It wasn't the pain. It wasn't that they didn't like the food. And they still ate just as much as the other ones, even when they were given free access to it. So they still had an appetite. So it was the motivation of pushing through that little barrier, poking their nose through the hole to get the food. That changed. Why did that change? Well, the researchers narrowed it down to a small part in the brain known as the nucleus accumbens. Now, if you're unfamiliar with the nucleus accumbens, you might familiarize yourself with it to some extent. It is the part of the brain, sort of in the middle part of the brain, that is responsible for our reward center, right? We have a lot of dopamine transmission that occurs in the nucleus accumbens. And there's lots of connections with the rest of the brain that helps to control our behavior or dictate our behavior. And there's been lots of studies with the nucleus accumbens as it relates to addiction medicine. Certainly, the nucleus accumbens sort of gets fried, you can imagine, with all the dopamine that occurs that can occur with addiction, right? Well, the same thing is true with chronic pain. I think this is maybe another example why we sort of say chronic pain and addiction are sort of two sides of the same coin. Not to say that the implications are the same, obviously two entirely different processes or clinical syndromes. However, both affect the nucleus accumbens. And so if the nucleus accumbens is dysfunctional or not acting in the way that it should, not communicating with other parts of the brain as it should, it can significantly affect motivation, you can imagine. What's interesting here, they concluded that there is an enduring downshift in the excitation transmitted by the nucleus accumbens. And I guess bonus points, there's a particular neurotransmitter known as galanin. This is sort of off topic, but they were able to narrow that down to one particular protein, a neurotransmitter in the brain that played a critical role in this. And I think that's going to be important, hopefully, for future research, perhaps even a treatment that could come around. Until then, the jury is still out. But that's sort of interesting, right? Like this idea that, oh, well, maybe it's not just my lack of willpower. Maybe it's not just my own laziness, right? Because we are often our own worst enemies. We're very hard on ourselves. It could just be the brain itself dysfunctioning within the disease process of chronic pain. So what do we do with that? Well, until we have more research, really it's behavioral intervention, right? And so if you're still with me after learning about the little mice, we're going to talk about now what we can do to maybe overcome this. Okay, I know that's why you're all here. So I like to refer to this as the motivation ladder. And there's, let's see, 1, 2, 3, 4, 5 steps. That's not too bad. 5 steps. The first step in the motivation ladder, Kevin, why don't you go ahead and pull that up? The first step is safety first. Okay, safety first. We want to reduce the threat of what pain is to your body. And that's where I come in. So you come see a physician and, you know, you're afraid. You could be afraid. A lot of people are afraid. It's natural. If I was hurting, I'd be like, what the heck is going on? Am I dying? I need to figure this out right away. You go in, you see the doctor, a physical exam, a good history, a physical exam, maybe some imaging, maybe some nerve studies, some lab tests. Let's figure out what's going on. Let's diagnose you. You know, if you're experiencing significant amounts of, let's call it amotivation, right? I want to make sure there's no other health problems that are contributing to that, because that honestly could be a big part of this whole discussion. What health problems do we know that can contribute to that? Well, I mean, your thyroid could be low. You could be suffering from adrenal fatigue. Cortisol could be low. Testosterone could be low, especially if you're maintained on long-term opioid therapy that dramatically reduces your testosterone. Of course, you could be anemic or have other blood issues, other health issues. It could be psychogenic. You could be suffering from overt depression, right? Or bipolar or something along those lines where it's just zapping your energy, your inability, your ability to move, to talk. You could become catatonic, all these things. That could be a big factor also in why you feel like you just don't have the gusto to get what needs to be done. So once we kind of evaluate for all those things and rule all those things out, really we want to just say, okay, I hear you, I validate you, this is a significant concern, and we can't rule it out on, rule in other things. this could be just a process of your chronic pain syndrome, right? And that's okay. So safety first. We want to neutralize the threat. That's rule number 1. All right, the next thing on the motivation ladder is tiny wins. We want to see success before we ramp up intensity. Okay? And Jose was talking about this the other night, which I thought was fantastic. Yes, there are some things we have to push through, but like he said, doing it intelligently, in baby steps, right? Knowing that you're not going to further injure yourself in the process. So tiny steps, right? Tiny wins. Keith does this every time at the end of his podcast, right? He wants to celebrate the wins. That is valuable, and that is on the motivation ladder to get you to a better place. There's a reason behind that. Number 3 is consistency. We want this to be repeatable. We want to be able to initiate a plan and then continue that plan from day to day, from week to week, so that we can see all these little tiny successes add up over time. And if you do this over time, there's rule number 4, or step number 4, you experience an identity shift. An identity shift means that, hey, I'm not someone who's stuck. I'm not someone who's incapable. I am someone that can follow through on something. I am someone that can make progress on something. So it's sort of reversing the downward spiral of negativity that we so often find ourselves in when these types of things occur, this chronic pain syndrome, where it's so easy just to predict the next day as being a negative experience. Oh, man, I'm hurting. I hurt yesterday. I hurt today. I know I'm going to hurt tomorrow. I know I'm not going to be able to do this. I'm worthless. I'm ineffective, right? Nobody's going to care about me if I can't provide, right? All of these things, and it becomes catastrophic, this thinking. I'm never going to get better. This is my entire life now. My life is over. I might as well throw in the towel. That's a horrible place to be. And if you're watching this right now, please know that there is a way out. And the way out is through this protocol. Safety first. Make sure you're not injuring yourself. Enjoy the tiny wins. Make sure what you're doing is consistent or repeatable. And what you'll find is that your identity starts to change. You start spiraling up. Okay? And I'm not trying to turn you into a gym bro. I am trying to turn you into somebody that can trust yourself again. Right? That's really what it boils down to. And once you get all through that, you're looking at progression. Progression is the next step. And that's where you build strength. Right? Notice in all of these steps, I did not say motivation. Because motivation is the side effect. Motivation is almost the destination. It's not a prerequisite. And I think so often we use the lack of motivation as sort of a barrier to entry, but it's not. Safety is our barrier to entry. That's the first step on the ladder. And so, that's sort of how you would get there, and you can continue to build on that.
I think it's when you say you have the safety and then small victories and then consistency and then, kind of like that. I think especially with small victories, I think it's easier to, it's not just about acknowledging them, because I think we're always harder on ourselves than the people around us. And it's easier to say there's small victories than to actually give yourself the small victory. That identity change, that shift in mindset is allowing yourself to enjoy those small victories you've made yourself. And I think as well as those little steps, it's always about that first push. I like to think of it like a boulder. It's hard it's hard when you see it huge. And the first hardest thing is just getting the ball rolling. But I mean, even once you get it rolling, it's easy to be like, wow, I'm actually doing it. It feels good. And once you finally, even if it's a small task, once you finish to completion, we always think about it afterward with that, hindsight. And it's like, wow, I don't know why it took me so long to get there. And it was just that initial, getting the ball rolling.
Yeah. And I think, I'm not looking at the comments actually right now. I will definitely get to that at the end of this, but I can sense perhaps there's going to be people in the comments that say, well, doc, I'm already doing everything that I possibly can, right? I'm already doing the exercise. I'm already taking the meds. I'm modifying my diet, and I'm just running around like a hamster wheel, and I'm not seeing the progress, yet I don't feel motivated to really add anything more and do anything more, right? Would you say that's a fair assessment?
Absolutely. I mean, yeah, when it's especially when you go to see a medical professional, it's always like, well, have you worked on that plan of care? Like, what have you done to move and do what we've talked about? Have you been doing PT? And it makes you, I would imagine it makes you feel small, because I mean, I've been in that scenario, and it makes me feel small, because I know that I do need to work out. I do need to eat better. But I mean, when I have bills and I have appointments and I have, my family, expectations of me, as well as, my doctor expecting me to do better for myself. And, it's hard to feel like I'm moving anywhere when I'm judging my progress by what other people are expecting of me rather than my own metrics. It's easier to swallow those big steps when I've really set out my own steps, my own plan, and, am allowing myself small victories because I've actually thought about what a small victory is to me.
Right. Yeah, and that's a crucial point. You definitely want to live by your standards on this, or the standards that you set with your physician, right? Yeah, family members, and by the way, this show is not just for patients with pain or looking to live a healthier life. This show is for family members too, right? Because I think a lot of times patients in the healthcare field, especially those dealing with chronic pain, they're often misunderstood by those closest to them, right? Family members included in that, friends, neighbors, things of that nature, the community around you. And that's because they are almost, or you feel like they're judging you based on what they expect of you, right? So if Thanksgiving is coming around and, you're responsible for cooking for Thanksgiving for the holiday, and you know that you just can't do it because of your pain, your back pain, that can be extremely demoralizing, because again, you're not necessarily living by your expectations. Maybe you are, but you're living by your family's. And there's a certain shame that comes along with that. And also the same thing is true with your therapist or with your physician. If they're giving you expectations that may be outside of what your goals are or your capabilities are, well, again, just trying harder is not a plan, right? So to address that, Stanford really takes the win tonight as far as holding down our research-based approach to this. But they do have an answer to this. It's known as the Stanford 5, and it's a quote from Sean Mackey, published in the Pain Chronicles in 2010. So the Stanford 5 essentially helps us understand, as practitioners, helps us understand the patient. And you can take these tools yourself as a patient and take them to your next visit and make sure that you both are aligned on that. Okay. The first of the Stanford 5 is, we need to know as a practitioner what your belief is about your pain. So let's use Evelyn as an example. So Evelyn, you said you're coming in with back pain, let's say, right? Everybody's got back pain. You're coming in with back pain. I think it would be important for me as a practitioner to know, what is it that you believe about your pain? What is the cause of your pain? What do you think is the cause of your pain? If you think it's a herniated disc, then I better address the presence or absence of a herniated disc. If you think it's God punishing you, then that might take a different treatment approach, right? I mean, I'm going to rule out the things I know I need to rule out, but as far as the treatment plan goes, what you believe about your pain is crucial in how I approach that, right? The next is the meaning. So first is what you believe the cause of your pain is. The next one is the meaning of your pain from your perspective. And then number 3 is the impact of pain on your life. Again, your perspective. So you tell me, what is pain really doing to interfere with your quality of life? What is pain really doing to make you feel like you're missing out, or make you feel like you're letting others down, or make you feel like you're letting yourself down, right? And understanding that, again, helps me understand where the treatment plan needs to go. Number 4, what are the patient's goals, right? What is it that you want to do? You know, I think it's easy just to say, you know, to whitewash everything with, well, I just need to be out of pain. Okay, well, even healthy people have pain, so we need to kind of fine-tune that just a little bit, right? But what are the goals that you want to accomplish? And then number 5, what is your perception, the patient, your perception of the appropriate treatment? Because again, if I'm giving you a treatment now that you're not fully on board with, or you're not subscribed to, and this kind of like comes on board with, well, I know you expect A, but I'm going to force you to do B because that's what I do, right? That can be demoralizing as well. So we need to align on all those things. What you think your pain is coming from, what does it mean to you, how it's affecting you, what you think the appropriate treatment is, and what are your goals? I think once you are able to have that discussion, you can really, again, you can fine-tune the treatment protocol and initiate the motivation ladder, because, again, a lot of us are running on hamster wheels, right? A lot of us are running on hamster wheels thinking that we're doing everything we need to be doing, not getting anywhere. Well, maybe it's just a lot of noise. Maybe it's not that, you know, that you need to lift 20 barbells every day and you know, and then that'll get rid of your pain. Maybe it's not that. Maybe it's just you need to build enough endurance in order to load the dishwasher, right? So I think in that way we can sort of cut out all of the noise and answer the person that's saying, but doc, I'm already doing everything. How could I possibly do anything more? Am I getting close on there? I hope I am. I mean, I know that all of this is like easier said than done, but without a medication that affects the nucleus accumbens at this point in time, this has been shown to really, I think, provide a lot of clarity for someone.
Yeah, because obviously, you know, pain is not only just in the body, it's in the mind. I mean, just like you said, you know, with your mindset, you can't just, you know, think happy thoughts and, you know, happy vibes will fix everything. Absolutely not. But I mean, you know, when what you're asked of, you know, from whether your provider, you know, your family, those expectations, again, I think when you're not aligned, when you're not receiving even a treatment that you think works. I mean, if you come into, you know, to come see a doctor, and I already have this notion that, well, I don't think a stimulator will work for me, or I don't think injections will work for me, or even, you know, I think medicine won't work for me. If you're only being treated with medicine, or only being, you know, recommended a procedure, I mean, how do I feel like I'm being heard at all? And if my mind doesn't match what is being asked of me or what is being recommended, I mean, it's hard to even think it's going to work at all. And I think it's easier for your body to be healed when your mind thinks it will be healed. When your mind, you know, reassures this thing you're doing. If you think you're doing something with no motive, with no purpose, then what reason do I have to do it at all? You know? Exactly.
Yeah. And I'm very hesitant about doing any treatment on a patient that a patient thinks is not going to work. Right. Now, I mean, of course, as a physician, I'm going to do what I can to sell a patient on an idea that, well, here's why it's going to work. Let's have that discussion. Here's what I'm thinking, because I don't expect you to understand everything in pain management, you know, but there are some tools I think would be helpful for you. But even if after I explained it to you and I answered all your questions and I went over the risks and benefits and, you know, all the studies and all that stuff, and you're still like, you know what, it's just not for me. Well, then I shouldn't do that treatment because... And what's even worse, I shouldn't link that treatment to, let's say, getting your medication filled, because I just think that's cruel. Now, we talked about this, you know, some before. We're getting a little off topic, but this idea that there's multiple things you can try, and that's the point of it. That's the point of it. It's not just stimulator or bust. It's not just injection or bust. And, you know, a lot of you have already done a lot of therapy, and maybe you're better, maybe you're still, you know, I don't want to say struggling, but let's say living day to day, right? Who isn't living day to day these days? So that's where I'm kind of coming at it from. There's always something different, and that's where the Stanford 5 is so valuable, I think, because again, it helps to align the physician and the patient, or the therapist and the patient on an alignment, on a track that they both can agree upon. And that's going to cut out, again, a lot of the noise. And at that point, you can approach the motivation ladder with a fine tuning. You say, well, this is what I want to do. Here's how I'm going to get there. And maybe getting your pain to a 0 isn't a reasonable goal. Maybe getting your pain to a 3 or 4, right? Or being able to load the dishwasher, or being able to go to the park with your grandkids, or your kids, or whatever the case may be. Like, putting it into those types of goals, and then realizing when you reach those goals, okay, this is working. I can trust myself again.
Definitely. I think when you have goals like that, rather than I want to get to this percentage, I think when we have these kind of open goals, like I want to be able to move enough to pick my grandkids up or play frisbee, or I want to be able to stand long enough to make my kid their favorite meal for their birthday, or it's easier to have an open mind and to give yourself grace, to give your provider grace. It's easier for your provider to come up with better solutions when you approach your pain and, that healing process with an open mind. And I think it's better to have open goals, because then there's more options, and more options means, things you might not even consider would work.
I do agree you want open goals in the sense that you don't want to necessarily be self-limiting, but you definitely want specific goals, because in that way you can check off when you've accomplished them. Absolutely. And that feels good, right? Now, just to recap, and then I'm going to go into mistakes, because a lot of us can execute this to the best of our abilities and still make mistakes, right? We're all human. But again, first, the motivation ladder is safety first. We want to reduce that threat. Next, tiny wins. Celebrate them, right? We want success before intensity. 3 is consistency. We want this to be repeatable, so no big leaps or anything like that. 4 is the identity shift. That's where this starts to come in, because you see yourself becoming successful, and you start turning that negative talk into positive talk, right? And then finally is progression. That's where the real momentum takes place. And after all of that is the result of motivation. We all get motivated when we buy a stock and we see it jump up, and we're like, oh man, I'm going to be a stock trader. I'm going to read about all this stuff and become the next Elon Musk, right? That's real easy. And if you buy a stock and it goes way down, you probably don't want to do it anymore. You're like, oh, this is not for me, right? So we definitely need to see those wins, however small they are. So let's talk about mistakes. Mistake number one, waiting to feel motivated. Waiting to feel motivated. If you wait to feel motivated, you're going to wait until Jesus comes back, because a lot of this is not motivation first. That's the whole point of tonight, right? Don't wait till you feel motivated. Motivation is the reward. It's the side effect. It's what we're building to. And hopefully that simple paradigm is something that can change a lot of how we approach this, right? Mistake number 2, going from 0 to 100. Don't do that. I don't know about you, but every time I think about starting to go work out again, I go in there and I lift like 1,000,000 weights and I do 1,000,000 push-ups, and then I never want to do it again after that because I'm too sore, right? That's a simple but common example of how that can happen. But the same thing is true with anything in life, right? And actually, Jose's going to talk about that tomorrow. I'm excited to hear about that and maybe some of the strategies that we can employ to, again, get these small wins with consistency over time, right? But yeah, don't go from 0 to 100. The nervous system doesn't like big jumps. It's scary. It's unsettling, unnerving. We want it to go nice and slow, right? If you're going up the steps, you do one foot and you bring that same foot, the other foot up to the same stair, nice and slow. And you may not even realize the progress you're making in the moment until several days, several weeks later, you look back, right? And you're like, wow, look how far I came. Mistake number 3, chasing pain-free before moving. Chasing pain-free before moving. So, as a pain physician, one of my roles in helping somebody participate in therapy is by controlling their pain. Makes sense? So what I'm going to do is, maybe give you some medication, maybe do a nerve block or something like that so you can tolerate the exercises more. There's definitely a role for that. But if you wait until you're pain-free to do something, again, you may not ever do that thing. Even if you don't suffer from chronic pain, we all have pain of some sort, right? And so the pain of effort in and of itself, right? And so, no, our goal is not pain-free to start. Our barrier to start is safety. Again, we just need to be able to trust our bodies again. We need to know that our movement's not going to break us. And that comes through, again, small movements over time. Finally, and this is hopefully something that we can all walk away with tonight, mistake number 4 is using self-hatred as fuel. Don't do that. Don't do that. Shame does not heal pain, actually, as it turns out. I studied this. I didn't publish it, but it turns out it doesn't help. So there you go. It actually just increases stress. Stress increases pain. So you got to stop being so hard on yourself. Give yourself some grace. Let your doctor give you grace. That's an important thing to understand, to accept, because I think, a lot of people in our lives maybe weren't giving us so much grace. Maybe that started from when we were kids. Who knows? But we're very hard on ourselves. We're very hard with what we think that we should be able to do, but we can't for whatever reason. And there's so much negative talk that goes along with that. All I can tell you is that you're human. You're not alone. Everybody's in this position of failing at something, right? We're all on a path of trying to become better, or arguably we should be. But that's okay. That's your journey, right? That's where you're at along the process. Sitting on the sidelines deliberately, okay, maybe you can be a little hard on yourself because you don't have to. Life is a game. Hop in, join. It can be great fun when you put it in the right perspective, right? So those are some of the mistakes that can happen. I think, I don't think we put up that picture of the nucleus accumbens. Can we put that up? I want people to see where this is in our brain, so we can sort of put a name to it, put a picture to it. Yeah, so I'm going to cite this. This is from a study here, actually a neurosurgeon, I believe. But yes, this is a beautiful diagram of what the inside of the brain looks like, particularly as it relates to the nucleus accumbens. So you can see that circle sort of right in the middle there where it says capital N, capital A, lowercase cc. That is the nucleus accumbens. And that's where it connects with all the other parts of the brain, not only the midbrain, but even the higher thinking parts of the brain, such as the prefrontal cortex, right? Our decision-making that controls our behavior, our personality, the decisions we make, our ability to say yes or no to things, right? And that you can see sort of how much of an interplay that is. That is, again, to bring it back, that is the part of the brain that was affected or theorized to be affected in the mice, where their motivation was zapped because they didn't have that reward pathway, that circuit that goes back and forth and says, hey, this was a good thing to do, keep doing it. No, it just doesn't exist. There's one more picture where the study came from. If you want to pull that up, it should be right next to it. Yeah. So this was published in the Journal of Neurosurgery. Dr. Han Yan, to give him credit, is the primary researcher there. And essentially, it's a systematic review of this entire concept with regard to the nucleus accumbens, motivation, effort, as it relates to lots of different disease processes, including addiction, substance use disorder, obsessive compulsive disorder, mood disorders. It was interesting. They did have a line in here, if I can pull it up, where they did mention the few studies that actually studied the role of the nucleus accumbens in relation to pain. So here they cited functional connectivity between the nucleus accumbens and the bilateral medial prefrontal cortex. That's the higher thinking part of the brain. That is thought to be significantly increased among individuals who recovered from pain, rather when compared to those who experienced chronic pain. So again, that was again citing 1, 2, 3, 4 different studies here in this publication. So again, the research is scant, admittedly, as it relates to chronic pain, but the concept is there, and we know the concept is there also in, let's say, larger studies that look at other conditions. And so take some validation in that, right? Again, assuming that there's no health problem, right? We've ruled everything out in the beginning. Safety first, right? To deal with chronic pain on a real long basis can affect the brain. We know this. Some of the functional MRI studies showed a smaller nucleus accumbens, like anatomically smaller in those patients with chronic pain. Again, they're functional MRI studies. What does it really mean? I don't really know. But again, it's something that is alluding to the fact that there really could be some consistency across multiple small studies over time. So yeah, give yourself some breaks, man. It's okay. It's okay. The brain is neuroplastic, which means it changes over time, right? Parts of our brain that we strengthen get bigger. Parts of our brain that are smaller or that we don't use get weaker, right? This is one of the reasons why exercise is so important in preventing dementia. Raise your hand if you knew that. It's kind of a weird concept. But why does that happen? Because nerves in our brain go to our spinal cord, go to our muscles, and the more we're activating those nerves, keeps the brain alive, right? We know that people with addiction suffer from smaller frontal lobes over time. And so we give people with addiction grace because their ability to say no is diminished over time. I've talked about this before. Maybe we'll do a more deeper dive on it in the future, but that's my point, is that it really is, if you don't use it, you lose it when it comes to muscles, but also the brain. And so what that means is it can be recovered. Your motivation will improve over time with following the step ladder of motivation. You got to prove it to yourself. You got to prove that you can accomplish small things over time. But the plan has to be specific to you. And that brings it back, again, not only to the Stanford 5, but our whole purpose on this channel is to emphasize the need for individualized care, right? You got to be on the same page with your therapist. You got to be on the same page with your physician. You got to know each other and the goals that you're trying to accomplish. So hopefully that's helpful. I'd love to get into the comments and see what you all are saying. I've been talking in the blind here.
I think definitely the whole, mind-body connection, and really it's easier to be kind to yourself and to see yourself, doing better, giving yourself small victories when you change the thought from perfection to consistency. When you're celebrating being consistent rather than perfect, it's a lot easier to be nice to yourself about where you are, and it's easier to see progress that way.
Oh, yeah. Yeah, one of the topics we're going to talk about is the pain personality, right? Do you have a personality that's, let's say, susceptible to chronic pain, to developing chronic pain? And probably, yeah, the answer is yes. A lot of people could, right? This type 1 personality, the perfectionist, so to speak. So we're always measuring ourselves to something that is, always unattainable, almost, right? And so we wear ourselves out, always chasing this. And what you're saying is true. We can treat both of these situations the same way. Give yourself some grace, man. It's okay. You're doing great. You're doing great. Okay, so you only loaded the top half of the dishwasher. You couldn't do any of that yesterday. Like, that's huge. And that's the game that we're playing. You know, that's the long road that we're on, the long road of life. You know, this isn't a one-stop quick fix. It's a lifestyle. Choosing health is a lifestyle. Lots of little decisions over time. If the more that you can understand that, absorb it, ingest it, believe it, see the progress in yourself, stop living your life by other people's standards, I think you'll be a lot happier.
You know, I like something Kate said here earlier when Evie was explaining some functions that she was working towards. She says here, can we normalize function goals over numerical ones?
Huge.
Shout out to you, Kate.
Huge. Yes, please. Please. Yes. No, that's fantastic. I hear you guys say this in the chat from time to time, but yes, I agree. I hate the 1 through 10 system. Hate it. But as far as objectivity goes, we don't really have much more to rate your pain off of. You know, pain is subjective. Pain is what you tell me it is, right? So, you know, how do I use the pain scale? Well, number one, I use it to get paid. Full transparency on that. That's part of our documentation requirements. That's part of, you know, making sure that we appropriately assess your pain, and using that pain scale or a pain scale of similar nature is important for that. Another way I use it is to sort of give me some trends, right? So if you first come to see me and you're rating a 10 out of 10 pain, and then maybe, you know, 3-4 months down the road, you're giving me a 5 out of 10 pain, that number may not mean much day to day, but again, over time, that might mean something, right? So I kind of use it like that. Another way I use the 1 through 10 scale is, let's say, you know, you're coming in with an 8 out of 10 pain and you're on a high dose of medication. And maybe I suggest, well, you know, we've been increasing your doses, but your pain really hasn't gotten better. Why don't we try reducing your dose? See how that works. Because, you know, I know it's a hot topic, but opioid hyperalgesia does exist. The way that you diagnose it is by reducing the pain medicine, and if your pain gets better, that would be a sign. Well, in this case, I'm thinking of one particular patient here in the last several weeks. I reduced this patient's medication down, let's say by a third over the course of, you know, several months or whatever. The pain was still an 8 out of 10. Okay, well, hey, that's still a win. We're on a third less medication. It's cheaper, it's less risk, less pills to keep track of, and your pain is kind of the same. Okay, well, we'll take our wins where we can get it, right? So there's some ways that you can use the 10 scale, but yes, man, using functional outcomes is huge. However small they are, to be able to demonstrate that progress is huge. It's huge for you to believe that whatever treatment you're doing is working. It's huge to your family members to see that, yes, even though day to day the progress is small, but week to week and month to month the progress is bigger. That's huge. And honestly, it's good for physicians to be able to document, to be able to prove to their governing bodies that, hey, what we're doing is working. So yes, normalize functional outcomes. It's this close to being probably primary. I don't think it's still primary yet, but definitely in our documentation, it should be included, and it is included in a lot of cases.
I think Keith's, you know, after we said that whole giving kindness to yourself, he said that it's almost impossible, you know?
Yeah.
It's almost impossible to give kindness to yourself. And I mean, you know, it's crazy to think that, you know, such a kind person, I mean, all of these people are, I mean, the whole community's so kind to each other. It's hard to see that, you know, can't even, you know, extend that own grace to ourselves. But I mean, we're our biggest bully a lot of the time, especially when it comes to pain. It's harder to be to see the positive when, you know, you're putting all this effort in, and, you know, like someone said, it's hard to get up, never mind function, you know, to see we're not where we want to be. We're not out there playing with our kids or grandkids. We're not out there, you know, making Thanksgiving dinner.
There's I guess you might call it a thought exercise. It's a psychologic treatment. And I'm not a psychologist, so if you're a psychologist watching this, I am sorry for butchering it. But I don't remember the name of it even, because, again, I'm not a psychologist. But I did it one time. I found a video on YouTube where there was some nice music playing and, you know, a nice voice worth listening to, better than mine. And it was a thought experiment. Maybe you've done this already. But it was profoundly impactful, even for me, to go through that. And the idea is that you close your eyes and you imagine walking down your childhood home, your childhood street, right, in your old neighborhood. And it doesn't matter if you had a good childhood, bad childhood, the thoughts are still there, the feelings are still there. And especially if you're dealing with this in adulthood, right? This idea of living in fear, not trusting yourself, thinking so little of yourself. And I'm only sharing this because it worked for me on a lot of, you know, let's say ways to grow up, ways to understand life. It changes also, I think, when you have kids, your perspective on a lot of things. But also I wanted to see how it might work for patients. And so, you know, like I said, I went through it. So imagine if you're walking down your childhood home, your childhood neighborhood, and you see your home there at the end of the street. And you notice the smell in the air. Maybe, you know, there's a nice breeze. The temperature is nice. Some leaves are falling from the tree. The grass is green but patchy in areas. And you get to the front of your house, and it's dark, empty, maybe abandoned, run down, and you're just thinking, wow, what happened here? And you walk up to the steps, and you knock on the door. Nobody answers. You look through the window. It's all dark. You see some light coming through, some dust, and it's empty. You knock again, and the door opens up. And who peeks through the door? What little 8-year-old you. And as an adult, you're encountering your child. Well, you as a child. And you say, no, I need you to come with me. And I wasn't prepared to do this tonight, so bear with me. But you look at your self as a child, and you say, hey, what's going on? And the child looks back and says, not much. How are you? Well, I'm okay. But who's here with you? Nobody's here. Are you okay? And the child might say, I don't know. I'm all by myself. It's dark. I'm scared. And you look at that child and you say, don't worry. I got you. You pick your child up, which is you, and you hold yourself close to you as a child, and you say, don't worry, bud, I got you. We're going to be okay. And then you walk away from that house, hand in hand, into the sunset. Okay. Like, if you have not done this thought exercise, like, I'm doing my best to keep it together here, and I did not do it justice, but it is a visual journey where you can find yourself again, who you were as a child before life got to you. And treat that child as you would any other child that you come across in a bad situation. And again, you don't have to have come from a bad home. I didn't come from a bad home. I know my mom is watching. What do you mean you came from a bad home? I didn't come from a bad home. I came from a great home. And a lot of people do come from great homes. Not everybody. But the thought process and the thought exercise, it still applies because of what you're dealing with now. And all I got to say is you got to try it, because it was a emotional release. Let's put it that way, where it's like, hey, I am okay. I think, a lot of physicians have the tendency to hold themselves to other people's standards. Of course, their patient standards, their Google reviews, their parents' expectations, their family's expectations, right? That's sort of a common negative that occurs in our field. And we often beat ourselves up for it. So just by taking that step back and saying, hey, it's okay. You're just a kid, man. You're just trying to get along in life. Have some grace for yourself. And it was huge. It was huge. And and to be able to make that journey and then come back to real life, I was like, okay, it's going to be okay. So hopefully maybe that's something that you guys can try. And if you have anything else that you've tried in the past, maybe you've spoken with an actual licensed psychologist, unlike myself, that has been able to provide you with some tools, put them in the comments. Let me know. Let other people know. There are things that can be done in order to train ourselves to be okay with ourselves.
I think that ties into what Katie said a little bit earlier. When I was talking about how this community can kind of be kind to people just like we're all like each other, and it's easy to go and jump and kind of defend somebody else, advocate for somebody else, but it's hard to do that for ourselves. I think that ties into it, taking a step back and saying that yes, we are ourselves, and it's like, well, I'm fine. I'll do it's whatever. But they need me more. But you need you more. You're not just you. You're that kid that you were so long ago. And maybe taking that step back will be able to let you find that fight or flight you feel for others in yourself or yourself. I think that's something we all need to work on.
Yeah. Yeah, it's not a decision. It's not, a simple action that you can employ and feel better the next day. It might be if you have a breakthrough, but a lot of times this is long-term work. It's long-term understanding yourself, the people around you, the world around you, and realizing your true identity, which is not someone who's suffering with pain. That's not your true identity, and it's not the end all. I don't believe it's the end all, not in this life anyway. So yeah, that's I wasn't prepared for that, to be frank, but I think such an important topic in understanding motivation, and so much of that comes down with just giving ourselves a little grace.
Oh yeah,
absolutely.
Yeah.
I think maybe when the stream's over, we can leave that link to that video you watched, along with the citations for everything else mentioned.
Yeah, absolutely. All right, guys. Let's see. Did I miss anything in the comments?
Well, there was something that was a little interesting that stuck out to me. I'm not sure if this is a thing, but someone was asking about why there couldn't be. Hold on, real quick. Let me scroll back up. Something geared toward being hold on. Yeah, here we go. Why can't we be put into inpatient rehab for physical therapy?
Oh, yes. Boot Scooter, is that right?
There we go.
Yeah. Thank you for that comment, Boot Scooter. So I was going to say in my free time, in the mornings, I do round at a inpatient rehabilitation hospital. So I serve as a medical director there here in town. Yes, and we do admit patients who are suffering from chronic pain. Actually, we do not infrequently, even from our clinic, we'll say, hey, it looks like your pain might be getting the best of you right now. You're sort of struggling to keep up with things. You're falling, right? We got to get you into rehab where we can do some intense intervention here. Manage your pain, let's say, stronger in a more supervised environment. Get you up doing 3 hours of therapy a day, right? And then we would keep you for about 2 weeks, let's say on average, depending on the individual. Yeah, that's a huge thing that can be done for folks with chronic pain, because, yeah, we can manage pain on an outpatient basis. Certainly that's done commonly, but sometimes the pain gets away from us, or our inability to function gets away from us. And yeah, we just need a more structured, supervised environment. That's a huge win on that one. If you can, get your primary care doctor to send a referral to a rehabilitation center in your area. It's called acute inpatient rehabilitation. Don't confuse that with a skilled nursing facility. Yes, they do rehab in a skilled nursing facility as well, also known as a SNF, or even a nursing home with rehab attached to it. Nothing wrong with that, but they do less intense therapy there. So maybe 3 to 5 hours a week versus 3 hours every day in acute inpatient rehabilitation. So yes, definitely check that out if you are a candidate for that. I'm sure your doctor can send that your way.
Got another one for you. Can chronic pain that isn't treated well cause seizures?
Ooh, that's an interesting question. I don't know of a direct link with severe chronic pain and the initiation of seizures. I suppose it's possible. Yeah, if your body gets ramped up to the point where your brain sort of is overloaded, I suppose that would be possible. But I don't know of a commonly cited or expected direct link there. If you withdraw from certain medications, that can definitely increase your seizure risk. So baclofen might be one of them. Certainly any kind of benzodiazepine can be another one, where yes, if you were to stop those medicines cold turkey, the risk of seizure is real. And there's a few others that may also lower your seizure threshold. I believe tramadol also can lower your seizure threshold just off the bat. There may be a few others, but seizures and chronic pain, it's definitely a consideration as far as the decision making and the plan that we provide to the patient. But as far as just pain equals seizure, I don't know if that's necessarily a case or a direct link, unless you're just naturally prone to seizures. Yeah. Okay.
Well, I think Jamie had a question. She was going to ask earlier, I don't know if we've already answered your question, but if motivation was related to spoon theory. Have you ever heard of that?
Spoon theory. I've heard of it, but I don't know enough to describe it.
Well, it's like every day you get like a set amount of spoons, and, taking your medicine is a spoon, and eating is a spoon, and, walking your dog is 2 spoons. And like by the time you've done everything, just basics, you've run out of spoons.
Yeah.
Like every day we have a set amount of spoons. Well, I guess what I think of that is, because I'm the same way. I like the spoon theory. It helps me mentally, like, rationalize how I feel about myself and, my energy level for a day. I guess I would say not. Probably it would be, like we said, noise. Mm-hmm. Working mindfully, working smarter with our spoons rather than harder. I think it's easy to, like we were talking about this before the stream started, like the best way I can say, because I'm a youth, a teen, dirty room. A youth, yeah, with a dirty room. It's like, it's when you have a dirty room.
I'm an adult with a dirty room.
Yeah. Okay. It's easy to see everything on the ground and on the bed, and your bed's not made and the laundry's not done. And it's like there's so much stuff going on all at once, and I need to get it done. And it's easy for us to just kind of, especially me, is to just start doing it and just do everything all at once. But I mean, kind of splitting that task down to tasks of their own. Like, okay, let's see. We got trash on the ground. We got laundry on the ground. We've got a messed up bed. And I've got a box I need to unpack from moving. Well, first, stopping and be like, okay, let's address the clothes first. separate the clean and the dark. You know, go put the darks in the dirty clothes. All right, which ones of the clean do I need to fold? Do I need to put on hangers? And then once you do that, and you've completed that one task, and you're not done with the room yet, there's still plenty of stuff to do, but it's easier to, finish that big task when you're approaching it with a little task, rather than, picking up a shirt and then, I got to pick up this trash, and then, I got to start making my bed, and, this box, open the box. And now you got an open box, still goes on the ground,
Yeah.
It's a lot easier to spend our spoons wisely when we do it step by step rather than all at once, multitasking.
Yeah, no, that's true. That's, I guess, a practical way of describing what I would refer to as energy conservation.
Yeah.
Right? This is especially true for people with multiple sclerosis, for people with myasthenia gravis, right? Some neurological conditions that can drain your energy perhaps quicker than the average person. But it's also true for people with chronic pain, right? You only have so much to give. And so part of that strategy that you can employ is scheduling your tasks and scheduling them out. And, you might be used to accomplishing 100 things in a day, but maybe you can only do 50, and you can only do it during these times and all of that. So, putting that on paper also can be helpful because, again, it gives you something to check off to feel good that, hey, I'm still existing. I'm still accomplishing what I need to. But also it kind of gives your family members, too, some insights like, oh, well, hey, she or he's not doing everything that we maybe expected to them to do, but look what they are able to do. And, hey, that's good. That's awesome. That's progress. We should celebrate that. Yeah. Energy conservation, very important. All right, guys. Well, it is getting late. I got to get my boy to bed. He's over here just waiting to go to bed. Yes, sir. All right. Well, I'm going to get back into the comments here, make sure I didn't miss anything after the show. But thank you so much for watching tonight. We have a great week ahead of us. Tomorrow night, Jose is talking to us about movement and how that plays a role in motivation and effort, because not just more effort, that doesn't just mean it's going to be successful. Katie's going to talk about diet, of course, on Wednesdays, and we're going to hear all about why I'm making horrible decisions, apparently, with regard to my diet. She's going to give us some great insight on that. And then Keith will close us out on Thursday. Thank you, everybody, for coming in tonight. We'll see you next time. Bye-bye.